put the surgical sheath on it, on top, and you're already sterile. You palpate the pulse, and you enter with a catheter in a 15-degree angle, okay? Only when you cannot, it's a difficult insertion, even though you're palpating the artery, is when you use the assistance of the ultrasound, okay? So I'll show you both ways. Again, this is a manicure. Unfortunately, you have to pump, 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 so I can feel the pulse of the patient. Okay, and as soon as I feel the pulse of the patient, if the pulse is right here, I'm going to enter this way, like that, in a 15-degree angle. Okay? Let me show you the kit. This is no more than a wire, okay? This is the surgical sheath that you have basically a little hole on top. Again, I'm sterile, all right? So you prep the area and you put the sheath on top, all right? So you're gonna have lidocaine. This catheter is very long, so this is mostly for femoral A lines, okay, or brachial A lines. You have another shorter catheter, which is, this is for arterial A line, okay? As you can see, you have like a needle inside, okay? But you don't need to pass the wire through this one. I'll show you different techniques, okay? So basically when you insert, you connect the syringe in here and you pull out a little bit to create a negative pressure. So you're gonna take the cap of the catheter, and as always try to dislodge this a little bit so it will be easier when once you get the blood return, this doesn't get stuck and then you lose the artery trying to disconnect it. So always try to disconnect it. I don't know if you're able to see a little notch in that plastic catheter. You see it or not? You see like an indentation in there? You see it? So that goes up and actually coincides with the bevel, okay, of the needle. All right. So as soon as you get the artery and you see blood return, you're gonna basically pass the catheter through the artery. So this is a very easy technique. Okay. Another technique is like a Selinger technique, which we use for central access, for central venous access, when we're putting a central line. Okay, so again, you get this needle, see this needle, the blue needle, again has the same exact technique. At the end, you have a little hole. Do you see the little hole? Okay, this is another technique that basically you, again, negative pressure. You don't have the little notch, but you're gonna actually put the syringe, but not up to the top. Why? Because once you get blood return, then it's gonna be again difficult to disconnect, and you might lose the artery. So you basically put it loose enough so you can get blood return, and as soon as you get the blood return, you disconnect the needle. Of course, it's gonna be the artery. This is a very old technique, but how do I do it in clinical practice when I don't have the arrow? Because it's very expensive and you don't have enough. So basically when I get the blood, okay, and when I try to disconnect with these two fingers, and as soon as I get the syringe out, I put my finger on top, okay? Now, let me show you something. I have to get this ready before. I'll show you the entire technique, but I'm showing you basically how to do it without inserting first, so you can see the entire technique, okay? So as soon as I get blood return and I disconnect my needle and I avoid a flash, this is the wire, okay, that goes inside the needle. You pass the wire I don't know if you're seeing the wire coming out. You see it?
Yes.
That wire is not going to be curved like that inside the vein because it's going inside the vein. It's going to continue going straight. Okay? So as soon as you pass the wire, you're inside the artery already. You basically hold the wire, pull out the needle. Do you see it? Okay? And now I have my, which you have to disconnect from that needle, get the short catheter. Imagine that this is the short catheter, okay? So you put pressure here, and this doesn't break. It doesn't. No, don't be afraid. You get the wire, and you basically thread the catheter through the wire. This is a very old technique, but we sometimes have to use it. Okay? And you insert the wire in the artery. Okay? Do you understand?
Will there be blood coming out as you're doing all of this? Or it stops?
With the wire, no.
With the wire stops?
No,
Okay.
no. And as soon as I have my catheter inside the artery, again, I have to remove the wire and put my finger here. And as soon as I have my finger, I get the connection of the A line, and it's gonna be projected to the monitor. Okay? Yes, you have to suture. All right? So let's go through it.
But that part's not supposed to be like hooked like that, right? Or
What?
that part right there that was just kind of hooked.
No.
It's not supposed
Inside the artery would never be
not
hooked.
inside.
straight.
You go straight.
It goes straight. Okay? So, again, let me show you the ultrasound technique. So again, as soon as you feel the pulse, in reality it's a blinded procedure because it's like doing an ABG. So you don't need in reality an ultrasound unless it's really difficult to get the artery. You will need it for the central line insertion because the problem is that even though I have done it a lot in Cuba through anatomy, a lot of pneumothoraxes can occur because it's one of the major side effects. The apex of the lung is very close, right? And also dilating the artery instead of the vein when you're going only through anatomy. That's the reason why we use ultrasound guidance for central venous insertion, which you're welcome to come at any point when we are teaching that for the DMP, but you don't have the benefit of putting hands on because you're not paying for this course, okay? So this probe is best for central line insertion because first it's very wide, okay? We use a small probe for arterial lines, but we have only one choice here. So I am going to show you how to do it. Any ultrasound has the capability of arteries and different organs. So before I went into this screen, basically I chose vessel. That's basically you go click on vascular and you have the different vessels, artery, veins, and then you click and then you are able to obtain which vessel you want to ultrasound. The same with the organs, okay? So when you're doing so again, I already prepped, and no, wait, I'll tell you. No, wait. Now pump. Okay. The vein is easily compressible, collapsible, because the walls are very thin, okay? The arteries, second, pulsate, the veins don't pulsate, right? And that's the major difference. You have to be able to differentiate between an artery and a vein, because in this particular case, we have to canalize an artery, not the vein, right? Otherwise, you're gonna get venous blood instead of, and you're never gonna get an arterial waveform or blood pressure accurately if you canalize the vein. We have to canalize the artery, okay? So the ultrasound has this arrow, okay? And depending on where you put the arrow, you're gonna see an horizontal view or a more longitudinal view. You see it or not? That's the entire vein, and why I know it's a vein, because I'm able to collapse it. Do you see it or not? I'm able to collapse it. So that would not be the artery. So what I'm looking at is the longitudinal view of the vein, okay? But because it's really difficult for me to get the artery as well in this view, even though I know it's lower. Do you see that it's pulsating lower? Okay? I have to do the transverse view, okay? Now, in addition, when I am inserting either an A line, which rarely I use it with the ultrasound, but for the central lines, if you put your finger or any syringe or any cap, whatever you want to use, you know exactly where your insertion is going to be. Do you see it or not? I'm straight in there, okay? Do you see that my needle is going through there? Okay, so I already have an idea where to insert my needle, okay? Because if I, for example, miss it and I go through here, I'm gonna go through the vein straight, you see? So before you insert the needle, so you don't have to do multiple sticks on the patient, try to not only palpate the pulse again, but if it's a really faint pulse that you can't palpate and it's only through visual, try to, with the same needle with the cap, without poking the patient, try to see exactly where your entrance is going to be. Okay? Got it?
Yeah.
So now, this goes away from the artery. So if I'm seeing my artery to my left side, the arrow has to go through the opposite side. Because if I put my arrows right here, look how the plane changes. Wait. Pump. Now if I stick here, you see that I'm very far,
The opposite.
and here I'm at the corner, and here I'm in the center, but that's the vein. It wasn't pulsating before. Okay? So you have to go opposite. If the artery is on my right, the arrow has to go to the left. But if you don't remember that, not a problem. You see the pulsating artery there? Keep pumping, pumping, pumping.
Yeah, es que no se abre.
Well, in this is a manicky. It shouldn't collapse both of them. Keep pumping. You're gonna be tired.
No, es que it doesn't
Oh, you can disconnect, because if you disconnect,
Then it will be on
your
my
blood is gonna run out. All right. So, again, palpating the pulse. If you want to use the or you can go straight through the pulse, or using the ultrasound, you will see the needle going in straight to the artery. Okay. So, let's get prepared. So again, from all those techniques, the arrow, the pencil is the best, again, but it's highly expensive, and they won't give you enough opportunities to use 3, 4, and 5, and 6. So you have to use only one. That's the reason we always start with old technique first, and then use, unless you're like super expert with the pen. Believe it or not, the old technique is easier than the pen. Because in the pen, you only see a very fine line of blood in here until slowly goes up. In the syringe, with the negative pressure, you see the flush right away, okay? So, did you rest?
I'm gonna do the neonatal resuscitation here.
So actually in this patient, I actually have 2 pulsating.
Yeah.
So let me just confirm. Something is wrong there because it's not even pulsating. Well, let's do it anyways by ultrasound view. Okay, so again, remember that I have my tiny indentation with the needle, and I have to kind of lose this a little bit so I can have And again, never start here. Always start. Never close to the ultrasound. Why? Let me show you another technique. If you put the needle right below the ultrasound, you will lose your needle as it enters. Why? Look. You need to be able to always have control of the tip of the needle, because otherwise you either pass the artery all across or never get it, okay? So you have to start a little farther, so by the time you hit the artery, you're able to see the tip of the needle, okay? Again.
Two of
Hopefully,
them.
yeah, I know. But hopefully the center one is the one that has that blood. But anyways, I want you to look at the technique and look at as the needle is passing through. So again, if you do this, you're gonna go straight to the center, you see? So right here. And again, 15-degree. Are you able to see the needle right there? Do you see it or not? But I'm not
On the top?
perforating the artery.
No.
So again, I can, and always have the ultrasound fixed, okay? So you can retract a little bit. This is really hard because it's
Not real.
plastic. Again, I'm all the way through. Supposedly I'm inside. I'm actually all the way through.
Maybe the one with the blood is the other one.
Yeah, maybe it's the other one. Again, none of those should be collapsible. And they left already.
Oops. Saqué la sangre, pues.
Yeah. It's not even pressing, you see?
Maybe.
Be careful, don't splash
Yeah.
everybody's face here.
Yeah, and then you're gonna get this too.
Stenosed.
Mm-mm.
Speaking.
Is there another one that can be used?
No, this is the only one.
The pump?
It's not even pressing. That's why you can't.
No, I was.
There's probably a little piece that's broken in there.
God. And this is new.
Or it's cracked, maybe, or it was faulty.
No, I'm just thinking of the mannequin.
Just,
Let's go lit.
And she's like 100,000.
Wow.
Esta mujer es cara. She's expensive.
She feels hard to get.
Yeah.
Just full of blood.
from the top.
Yeah.
Maybe if it goes back, se mete para allá.
Sí.
Oh,
Yeah.
It's supposed to be full of air, not full of blood.
See, I empty it.
Looks like you have two arteries.
Two.
You pick one.
es que se va a flashback para dentro del bulb.
Ah, that's good.
Yeah. It shouldn't be, it should be only one.
Collateral circulation.
I do think when they connected it, they connected it one.
Pero now it looks like it has blood inside.
Are you able to see the needle in there? Do you see that I'm moving the needle inside the?
Mhm.
But it still doesn't, it should have blood return, but it doesn't have blood return, and I'm completely inside.
Press the thing.
And that's the artery. You see the vein at the bottom? And this is the artery. And do you see my needle inside?
Yes.
Do you see the
On that
needle?
corner.
So it's actually, I'm in the right place, but it's the mannequin. Do you see the needle inside or not?
Yeah, the top one, right?
Yes.
Yes.
Do you see like a line, a
Yes,
bright
yeah.
line
Yeah.
inside?
White line there.
So that's the way that I can actually prove that I'm inside the artery. You see it or not?
Yeah.
That's the entire arterial line in there. Okay? So basically, I should have blood return. I apologize. So once I get blood return, remember, this one you don't have to disconnect. The only thing that you have to do is this. Go inside, okay, and remove the needle. You have to put your fingertip on top, okay, and connect the line. The nurse has to have everything ready for you, and you basically connect. Now, for suturing, even though I'm gonna teach you also suturing technique in 694, the best suture for arterial lines are straight needles. Okay, so again, let me show you the best way to suture an arterial line, even though I can't do it in the mannequin. I'm not allowed. We have another mannequin for suturing. Okay, the best way to suture is you pass the needle. Of course, the patient's gonna be with a lidocaine, right? So you pass the needle around the catheter, okay? Okay, and you can either cut here, which you don't need anymore, and get forceps and do the simple technique, or you could do a two hands technique. I'll show you the technique next semester. So again, you do this, okay? But remember, the catheter is right here. Look, it's right here, okay? So it's gonna be tight in there, okay? And if you do the two hands technique, again, you don't need to cut the needle. What you would do is, not in the skin itself, okay, you already passed one loop through the skin. Do you see the skin? You see that it's attached to the skin in there? Yes or no?
Yes.
Okay, so now you're gonna pass the needle, not through the skin, but all the way around. All the way around. Be careful with not sticking yourself, which I just did. Okay, all the way around until you have a decent loop in that particular sulcus. You see? It has to be very secure, because if the patient is aggressive or start moving, they're gonna dislodge the A-line. Okay? And once you finish, you can do a knot here, and you enter this way, you're gonna exit this way through the skein. Through the skein, and again, you're gonna do two hands technique.
So at least 2 stitches.
Yes, 2 stitches. And 2 hands technique. And you cut, and you're done.
So you went through the skin first,
You go through the skein first.
then you do loop.
You do a knot first.
do a knot.
And then you go around and around and around, and then you go backwards and you do 2 hands technique knot. Again, if you don't know how to do that, easy. You get a surgical kit, and I'm gonna show you the technique, simple technique how to do suture.
Okay.
Any question? Sorry about the mannequin.
Thank you,
It's not my
Leal.
fault.